Welcome to this Gimme 15-minute education program for medical professionals. My name is Jennifer Searfoss, and I am the CEO of the Searfoss Consulting Group. This presentation will address what you need to know about Incident to billing. This session, along with many others, is available for free through iTunes as a podcast or as a video archive on YouTube. Learn more at scghealth.com. One quick legal note. None of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have any questions regarding state or federal law that apply to the concepts covered in this session. With that, let's get started. As I mentioned, this session is covering Incident to billing, and we are going to cover a number of very important issues. We're going to start with explaining the Incident to rule, providing several examples for you. We're going to clarify how this works with private insurance, and then identify a couple of resources. The majority of the resources are different readings for you within the Medicare manuals. So let's start with Incident to billing. Incident to billing, if you haven't already heard of it, is a Medicare concept. It is only applicable to the Medicare program. Therefore, it is a federal concept, but it is something that, again, does fluctuate by state, and we'll talk a little bit more about state scope of practice laws. So an Incident to service is a service payable by Medicare that is in the continuation of a physician's treatment or diagnosis. So this does mean any practitioner that is considered a physician under the Medicare rules, so that does include podiatrists, that does include MDs and DOs. It's paid as though the physician performed the service. Therefore, it is paid at 100% of the allowable. You bill it under the Supervising Physician's National Provider Identifier. We'll talk more about that. It needs to be under direct supervision. And so it does require not only that direct supervision, but documentation in the medical chart of who was in the office suite. Because it is in continuation of treatment or diagnosis, it means that new patient encounters or the welcome to Medicare visits are not able to be billed Incident to. Also, this is only available for services performed by W-2 employees. It is not available for 1099 contractors. The last thing to keep in mind is that this is only available in the office setting, so it's place of service 11. Services must also be those that are quote-unquote typically performed in the office setting. So if you have surgical services or other services that are normally performed in a facility setting, those services would not be falling under the Incident to rule clarification. Another quick note, and I'll cover a little more on this too, is that physicians cannot bill Incident to one another. This is only for non-physician practitioners. A physician, and we'll talk more about that at an upcoming Gimme 15-minute session, but physicians cannot bill Incident to one another. So just please keep that in mind. It's one of the top issues that I run into. So Incident to services are available only for those services that do not have a defined category in the Medicare benefit. That means that, honestly, as I look at this list, Incident to services or devices or items are only applicable to, not applicable to ambulance services. There are no such things as Incident to ambulance services, so if you're looking at a way to do those, you can't. There are certain other items that can be billed Incident to. They have to be billed under the scope of practice of the individual practitioner that is doing those services. And then again, you're going to, if you're doing global, you're going to bill under the group. There's a number of other things. But again, Incident to does not apply to certain things. And that includes diagnostic tests. It's going to include x-rays, surgical dressings, DME, pneumococcal vaccines, any services performed by a certified registered nurse anesthetist. Please keep in mind that CRNAs are exempt from this. In screening mammography, screening pap smears, along with bone mass measurement. So let's talk a little bit about supervision, because this is one of the more difficult parts. Incident to services do require direct supervision, and that means that the physician who is being, that service is being billed Incident to them, and it may not be the physician who started this course of treatment or diagnosis, but the supervising physician whose NPI the service is being billed under must be, quote, immediately available in the office suite. This is a really important thing. They can't be across the street. They can't be taken rounds at the hospital. They can't just be available by phone. They can't have run out for coffee. They have to be immediately available in the office suite just in case an emergency happens for this to work. One of the things, too, is that the chart does need to document who was immediately available in the office suite. Now, if there's multiple physicians, again, you'll figure out through your processes how you want to do that and how you want to give credit to the physicians for billing these services. But remember, you need to document in the chart which physicians were there. And also, you need to make sure that the documentation is in the chart because, again, if you have who was available and on-site in a separate list of who was seeing E&M services, guess what? It's going to make your audit pull a lot harder. One other side note, there's a lot of questions about what happens if your office is several stories. As long as, again, the exam rooms are something that a physician could quickly be able to get to that exam room, that's really what this is about. This is about safety. This isn't about strict definitions. So if you have a stairwell where there is easy access, if there is an emergency, that's going to be able to qualify. But it does need to be as part of the actual leased space by that group entity. So more information on this one, again, I do recommend you contact counsel or feel free to reach out to me and I can give you some more guidance on that. Performance. Auxiliary personnel, those individuals that are not a physician, so registered nurses, technicians, other qualified personnel, they need to be trained. And this is one of the big things. They need to be trained, and there either needs to be a state scope of practice or in some way they need to be trained to be performing the medical services. This could be a medical technician. This could be an LPN. There's a number of different licenses and other medical site services that can be performed by these individuals, but the auxiliary personnel do, again, as we talked about, they have to be employees. Also, be sure that if the service on the CPT says that it's personally performed by a physician or as part of the Medicare guidelines, says it must be performed by a physician. This is a really big issue in podiatry. Make sure that the physician performs those services, and again, that you document that the physician personally performed those services. Now, a non-physician practitioner can be reimbursed so that the physician performed the service, and so they get paid 100% of their rate instead of discounted down to the non-physician practitioner rate. So oftentimes this is a way to increase your reimbursement, but again, you have to document there was a physician immediately available in the office suite. So here's the actual definition. So again, Incident 2 services are defined as services or supplies that are integral, although incidental, as part of the physician's personal professional services in the course of diagnosis or treatment of an injury or illness. So all of that, first off, needs to be documented. The course of diagnosis or treatment, what is that? That basically care plan has to be laid out and documented, and it doesn't have to, again, be in that nurse practitioner or PA or auxiliary personnel's chart. It needs to be documented in that patient's chart. Also, just a quick note on chemotherapy. The physician must affirm the treatment plan in documentation for any hydration, for example, to be covered. And then when it's performed under the direct supervision of physician, say that quote, performed under the direct supervision of a physician, and then identify the physician by name. I usually do full name with middle initial, and then I put their credentials at the end to make it very clear. But just a quick note, the physician does not need to sign off on the chart. It's not like you're in a teaching hospital. You don't need to sign off on the chart. But again, with that direct supervision and everything else that goes along with it, you do need to have control and, again, internal audit policies so that you make sure that the quality of those medical records do reflect what you expect to go out. So let's turn to some scenarios and, of course, some wrinkles because it's like English. Everything doesn't quite work. My first example is in a chemotherapy scenario where hydration for a cancer patient is documented for the need and treatment in the chart. A group physician is seeing patients in the exam rooms that are in that suite, and an employed RN is giving hydration in the suite. So this would meet the definitions of Incident 2. They would document the physician seeing patients at that time with those E&M services in the suite and bill under their NPI. And then they're going to use the 99211 for administration of hydration because this is an RN auxiliary personnel. That is the code that is provided in the internet-only manuals for Medicare as being the billing location, or billing code, excuse me. Let's talk a little bit about facility billing. This is, again, a related wrinkle. So there is no ability or even a benefit for Incident to billing in a facility under Part B. Instead, that's considered part of their global payment. But there is an opportunity for shared or split visit if that physician is having any face-to-face time with the patient. And so in that instance, you would bill under the physician NPI. So they have to have any face-to-face time. So the E&M service or documentation could be started by a nurse practitioner, or PA, CNS, or CNM. Guess what? It's only those four. Those are the only four really that have this benefit. But if any of those non-physician practitioners in the facility setting start the chart and the physician has face time, they're going to be able to bill under the physician's NPI. So it's not quite Incident to, it's just shared split billing. Likewise, in the skilled nursing facility and nursing facility locations, again, there is not an ability to bill Incident to unless there is truly a designated office space. And in that instance, again, because it's an office space, that's place of service 11 office, and those services by other auxiliary personnel or non-physician practitioner could be billed as though the physician is continuing that course of treatment. Otherwise, if it is not in a designated space that, of course, needs to meet all the Stark requirements for a leased space, you would actually, in that instance, then need to seek reimbursement from the skilled nursing facility or nursing facility. So generally, let's just clarify, shared and split visits in the office setting. Again, it's really nurse practitioners, PAs, CNS, and CNMs who are able to do this. But in the office setting, it really needs to be more than just some face-to-face time. It actually needs to be that the physician performs some part of the E&M service. And again, all of the other requirements of Incident to have to be met, but the physician steps in and has some face-to-face time in continuance of the E&M service. So let's do a scenario as part of that. So a physician assistant is doing rounds for an orthopedic group in a hospital. They start the E&M. The patient then begins to complain of significant knee pain, and then the physician joins the patient with the PA in this visit. In this instance, it would be a shared visit because both clinicians did have face-to-face time. It is in the facility setting, so it would be a shared split visit. Document both clinicians face-to-face for that encounter in the clinical chart. Also, you're going to bill then under the physician for one service. This is not two services. This is one service. And I'm going to note, and this is a big thing on audits right now, this, no matter what time of day the physician comes in and visits that patient, no matter what, it is going to be one visit that you bill for that day. So because there's an E&M service performed by the same group for the same signs and symptoms on the same day, there's no modifier you can put to it. And again, it's going to be billed under the physician's number because of the face-to-face encounter. So just keep that in mind. Otherwise, the physician assistant, again, should have privileges at the hospital. We'd assume that they do because they are having rounds. And again, they're credentialed with Medicare, so they would bill under their own number if they didn't meet these guidelines. So a couple quick wrinkles on this. So just as a reminder, again, from that scenario, the physician assistants, nurse practitioners, CNMs, CNSs, they all should be credentialed directly with Medicare because they do have their ability to bill under their own NPI. So let's say a physician gets sick and there's nobody in the office. Again, you'd not be able to bill for any of those services unless they have the ability to, again, be credentialed. So it's really wise to credential all of your non-physician practitioners just in case. They are paid under Medicare at 85% of the allowable. Incident to service are generally allowed by private insurance companies. They rarely clarify this in their provider manuals. Just know that. If they have a prohibition, oftentimes they will spike that out, though. So look for it. If it doesn't say anything, then you should be good. Make sure your clinical records are documented. But really, it's when they say that they prohibit it that's a big issue. And again, remember, too, that many of the health plans do allow direct credentialing of non-physician practitioners. So I want to just quickly contrast this. As I mentioned before, physicians cannot bill Incident to another physician. Instead, that concept is called locum tenens. There's another Give Me 15 Minutes program that is titled Temporary or Quick Start Clinical Staff that will go in depth on locum tenens, so look for that on iTunes and YouTube. But locum tenens is a Medicare-only concept and does allow for 60 continuous days of using another physician's NPI while you're in the process of getting them credentialed. So know that that is out there. More information will be given in that upcoming Give Me 15 Minutes. So your resources are the Internet-only manual. It's Chapter 60 in the main claims, which is 104 if you're a geek and want to look for those. And also, a number of the contractors have done their own FAQs, so I highly recommend that you check it out. We will also have a blog that's posted up on scghealth.com that goes in depth to the resources available to you, so I highly recommend you check that out as well, and it's just a quick, simple search on the website. So thank you very much for joining this presentation. I hope that you have enjoyed it. For those of you listening on a podcast or watching the video archive, please remember to rate this recording in iTunes or YouTube. To receive notices about upcoming Give Me 15-minute programs or other educational sessions, please sign up on scghealth.com. Thank you for joining me for this 15-minute education program. This concludes the presentation.